we have Dr. Adit Gupta. He's the director of Mumbai Eye Plastic Hospital, along with his partner, Dr. Prerna. So he's doing tremendous work both on plasty and functional oculoplasty. So over to you, Dr. Adit, who will be covering on cosmetic eyelid surgery complications.
A very good morning, everyone. All that glitters is not always gold. After seeing such wonderful results of blepharoplasty shown by Akshay, I'm going to turn towards the dark side of blepharoplasty. As the number of procedures done overall as well as in India increase, so are the complications going to increase. As we see, blepharoplasty along with eyebrow lift is becoming one of the most commonly performed plastic surgery procedure all over the world and now as well in India. So why do complications happen? Complications could be surgeon-related or they could be patient-related. Now, surgeon-related complications are something that we should be wary about. Patient-related complications are not in our hand, but their treatment is. Now, surgeon-related complications mostly are because of poor understanding of anatomy, lesser exposure to this subspecialty during training, or sometimes because of faulty technique. Eyelid is a very intricate structure. It protects one of the most stable and the vital sense, that is vision, and even small mistakes can lead to disastrous sequelae, and millimeters matter. If we follow this complete checklist before performing a blepharoplasty and customize, we don't end up with untoward outcomes. These are some of the commonest complications which occur with blepharoplasty and the not so common ones which are seen here. And I'm going to take you through some of them via certain pictorial depictions and case-based scenarios. When I started performing blepharoplasties, I was very excited. I used to be very aggressive while removing the fat. I would get good results in some cases as seen here, very good transition of the tear trough as well as the lower eyelid. But many a times I would be left with a hollow patient. Sometimes the patient would be happy, but sometimes they won't be. Unveiling the tear trough can lead to pigmentation and also a very hollow appearing eye, which is sometimes not preferred by many patients. So in such cases, as Akshay has already pointed out, you should perform a fat preserving blepharoplasty where you can either do a transposition or a fat transfer, which could be native fat or it could be from somewhere else in the body. Now, this is one of the commonest, I would say not a complication, but an after effect of a blepharoplasty when you're in your beginning phase of your career. You would see that the fat has been removed well, but there'll be a persistent lateral fat pocket which has not been addressed. Now, this is very common because this is the Eyler's fat pocket which lies between the crus of the lateral canthal tendon, and we tend to forget this or excise it because usually we approach the lateral fat pocket the last, and it is a little deeper in the orbit. It happens very commonly, especially in males, because the lateral canthus can also be a little tight. We always thought that orbital fat is two-dimensional when we begin, but actually it is three-dimensional, and the lateral fat pocket after the medial fat pocket is one of the deeper pockets which should be delved into deeply. A not so uncommon complication of blepharoplasty, especially the lower eyelid when the skin is involved, is eyelid retraction. This we see very commonly when a general plastic surgeon does this surgery. This is a middle-aged male who has multiple orbicularis laxity. You can see malar festoons as well as a retracted lower eyelid after a transcutaneous blepharoplasty and a lateral canthal dystopia as well. Now, these patients need to be dealt with carefully. They mostly, the physiology here is either excessive removal of skin or a pre-existing orbicularis laxity or weakness and gravitational tissue descent. These patients need to be dealt with by placing a spacer graft along with lifting the lateral canthal tendon and additionally performing a SOOF lift. They undergo, we can get good outcomes, but always the eye shape always appears changed even after performing corrective surgeries. A forced upward traction test is very important to do in these patients to determine if there is any tether, because then you need to address the posterior and the middle lamella as well. Now, when we address tether, there are two phases, the initial phase and the rehabilitation phase. In the initial phase, usually you should not be touching the patient. You should try all methods of scar modulation, which could range from filler injection to a simple tarsorrhaphy, which can be very effective in such patients if done at the right time, or filler injections along with steroids or 5-FU injections. Now, this is a complication which needs to be dealt with more carefully. I saw this patient around 6 months ago. She had an eyelid malposition. You can see a very frank ectropion in the left side, an early ectropion on the right along with eyelid retraction. The frank ectropion on the left was causing exposure along with dystopia of the lateral canthus. You can also see a hypertrophic scar here at the lateral canthus where the plastic surgeon has tried hitching up the SOOF. Now, these patients need to be dealt with very carefully. They need a lot of psychological counseling as well because they have gone through a disastrous result of a blepharoplasty. So to buy time, I usually perform a hyaluronic acid filler. It also acts as a spacer, which is a temporary spacer, also causes biomodulation and buys us time for 3 to 6 months till we perform a definitive procedure. It is usually done in the orbicularis plane, so there will be a little bit of fullness seen post-procedure, but that is fine. That is the trick to buy time. Sometimes eyelid malpositions can lead to entropion as well. So in this young lady, a transconjunctival blepharoplasty was attempted by a plastic surgeon, but because of aggressive cauterization and improper planes, you can see that the eyelid has rotated inside along with retraction. You can see the eyelashes are rubbing on the cornea, and this needs urgent surgery because it can lead to exposure as well as infective keratopathy. In such cases, you need to address the posterior as well as the middle lamella because this happens mostly because of volume collapse. So you need to add a spacer graft between the tarsus and the inferior phonacial conjunctiva to stent the eyelid up. So in this case, a canthotomy along with cantholysis was done. All the cicatrix was released. The inferior oblique muscle was also present and entrapped within the scar tissue, which was also released. And a fat strip graft or a dermal strip graft can be used as a stent graft in these patients, and you get very good outcomes. There is a little bit of bulkiness in the lower eyelid, but that comes at the cost of corrective surgery. This is one scenario which we encounter very commonly in young patients who undergo a blepharoplasty, especially males, post-inflammatory hyperpigmentation. Even I don't know what to do with this. This is a very tricky scenario. Sometimes antioxidants and certain times even pigment lasers with the dermatologist help in these cases. But usually males I have seen tend to develop this hyperpigmentation very often. Some may have mild, some may have moderate, but time is our only friend in these cases, and usually 3 to 6 months down the line, they tend to do better. Eyelid fold asymmetry is very commonly seen in upper eyelid blepharoplasties. This was a Northeast Asian patient whom we performed a blepharoplasty for. The first post-operative day, everything looks good, but after a month or so, you can see that the right eyelid fold is droopier as compared to the left, a little bit of hollowing here, which can explain the asymmetry as well. These need corrective surgeries where you need to do an eyelid fold revision, which can give good outcomes and a symmetrical tarsal platform as seen here. There are scar-related complications which all of us know how to manage. Usually they need time and scar-modulating agents. Silicone gels as well as scar-modulating gels work well in these patients. But these happen more so in patients with oriental skin profile because the dermis is thicker, so the reaction is more. And sometimes in repeat cases, these scar-related complications are seen more. The most dreaded complication of blepharoplasty is obviously a hematoma. This patient of mine developed a subconjunctival hemorrhage, which could also be because of seeping of blood from the transconjunctival incision. So you should be very careful about any bleeders left during the end of the surgery. But what we are more worried about here is the vision. So you need to do a thorough visual evaluation, and the patient should be given your contact number in case the eye turns red or is very painful. All of us don't want to see this complication. This is a picture taken from a textbook. Luckily, I had not encountered this in my life. But hemorrhage and blindness is one of the rarest complications, and we need to keep our radars on for this. If at all it does happen, then you have to perform an emergency cantholysis canthotomy and evacuate the wound. Meticulous hemostasis, preoperative stoppage of blood thinners helps in preventing this complication. So to conclude, the margin for error is very small in eyelid cosmetic surgeries, and majority of the complications can be dealt with if managed conservatively initially and then with a corrective surgery by an oculoplastic surgeon. Scar modulation and fillers should be used to our benefit in the initial healing phase, and counseling and psychological hand-holding is of utmost importance in rehabilitation. And you need to identify red flags or prior problem patients, especially a patient with a negative vector, a history of prior blepharoplasty, an unhappy patient. And last but not the least, I like to say that you should be very careful about this subset of patients with body dysmorphic disorders. They have a typical history of undergoing multiple procedures and wanting even more to correct the previous deficits. Thank you.
Thank you, Dr. Adit. That was an extensive and a very well presentation. And it's very rightly you have mentioned, I feel that especially in India, one of the toughest blepharoplasty is when you do a upper lid blepharoplasty for an Indian Asian eyelid, because they want a bigger, higher lid crease, and also the rest of their orientation is like of any of the Asian eyelids. So those type of blepharoplasties are very difficult because asymmetry is very common, or sometimes you find that the lid crease may not stay for 3 to 5 years as we do in the other types of blepharoplasty. And Adit has also very rightly mentioned that when we do a low blepharoplasty, we should always remember the fat is not two-dimensional, it is three-dimensional. The central is superficial, the medial is deep, and the lateral is deeper. And what he has mentioned about the isthmus, the lateral fat pad, many a times I get so many referral because people, they do blepharoplasty, but they do not, deal with their lateral fat pad, and you find the bulge post-blepharoplasty. So it is very essential that a clear understanding of the anatomy should be done very well before you take up such surgery. So I think we'll take all the question and answer.